Hello, I hope you all are doing well. Today I'll tell you about how to read an arterial blood gas analysis report, that is ABGA report. I will not be going into the physiology of acid-base balance, but I'll just tell you the steps how to decode an ABGA report. So let's begin.
ABGA presents itself with a set of few numbers which need to be interpreted as one result. It tells us about the activity in two systems, respiratory and metabolic. If one is disturbed, then the other one tries to restore the balance. Both are basically concerned with keeping the pH in the normal range. It is very important to remember their normal values so that we can interpret them correctly. Coming first to the pH. Normal value of pH of the blood is 7.35 to 7.45. The neutral blood pH is 7.4. At this pH of 7.4, the hydrogen ion concentration in the blood is 40 nanomoles per liter. Obviously, for every pH, there is a corresponding hydrogen ion concentration, which you can know from this table. You do not need to remember it, but you can keep a screenshot of this for reference as we will need this in our further calculations. Let's get back to basic chemistry. Remember, pH less than 7.35 is acidemia and pH more than 7.45 is alkalemia. But for practical purpose of ABGA, we will take 7.4 as neutral, then pH less than 7.4, you have to consider acidosis, and for pH more than 7.4, you have to consider alkalosis. Now, remember the normal values of bicarbonate, which is 20 to 28 milliequivalents per liter. The normal value of PaCO2 is 35 to 45 millimeters of mercury. The normal value of PaO2 is 80 to 100 millimeters of mercury, but it is dependent upon the age and altitude. Do not worry if the digits of PaO2 and PaCO2 are given in kilopascals. You simply have to multiply it with 7.5 in order to convert it into millimeters of mercury. Next, it is very important to know some ground rules. Remember, never comment on an ABGA without knowing the relevant clinical history. So always take the history first. Secondly, never interpret an ABGA without knowing a simultaneous electrolyte and serum albumin level. Normal value of pH, PaCO2, bicarbonate do not necessarily mean absence of acid-base disorder. Always complete all the steps that I am going to tell you subsequently. The very basic chemistry again. Remember, carbon dioxide is an acidic gas. Bicarbonate is an alkali. Body always tries to maintain the electroneutrality. Now just remember the definition of anion gap. Anion gap is sodium minus chloride plus bicarbonate. Usually the level of potassium is omitted from the calculation of anion gap. So in that case the normal value of anion gap ranges from 8 plus minus 4. Now what do we actually have to know from an ABGA? Well, we have to know if it is an acidosis or alkalosis or a mixed disorder. Acidosis or alkalosis, if present, is whether respiratory or metabolic. If it is respiratory, then whether it is acute or chronic. And if it is metabolic acidosis, then whether it is a high anion gap or normal anion gap metabolic acidosis. And what is the possible reason for low PaO2 if it is present? That is, we have to find out the type of respiratory failure if present. Now, as I told you, ABGA tries to tell us the activity in these two systems, that is respiratory and metabolic. If one is disturbed, then the other one tries to balance it. That is called as compensation. So you need to remember this table, which indicates the predicted compensation of the other system. You can see from this table that in chronic respiratory acidosis or alkalosis, the change in bicarbonate is higher as the kidney gets more time to adjust. Remember that acute compensation takes around 6 to 24 hours, while chronic compensation takes around 1 to 4 days. Respiratory compensation is always faster than the metabolic compensation. And remember, in clinical practice, it is rare to see complete compensation except in cases of chronic respiratory alkalosis. I'll keep this table handy up here. Now that we know all the ground rules, let us start decoding ABGA by these simple steps. First, always look at the pH. If pH is less than 7.4, consider acidosis. If pH is more than 7.4, consider alkalosis. Next, look at PaCO2. Ask this question in your head. Is PaCO2 contributing to or attempting to compensate for the problem? You have to keep it in your mind that CO2 is an acidic gas. If the pH is low and PaCO2 is high, that is higher than 40 millimeters mercury, then it is primary respiratory acidosis. Now, in this case, you have to find out whether this is acute or chronic process. So, just calculate delta H divided by delta PaCO2. Delta H is nothing but corresponding hydrogen ion concentration from this table minus 40, while delta PaCO2 is nothing but patient's carbon dioxide minus 40. If this ratio is more than 0.8, then the process is acute. If this ratio is less than 0.3, then the process is chronic. And if it is in between, then it is acute on chronic respiratory acidosis. Your next step here should be to calculate the compensation by this formula that I already mentioned. Now, since this is primary respiratory acidosis, so you will use this formula to find out the expected bicarbonate. Now, coming back to the situation where pH is in the acidic range but PaCO2 is low. So basically, PaCO2, that is respiratory system, is trying to compensate for the problem. So one can easily conclude that the problem is metabolic. Now just see, looking at these two numbers only, most of the vital interpretation is usually done. Now in this case, when the pH is low, that is in the acidic range, and PaCO2 is also low, which is basically trying to compensate for the acidosis. So here we will look at the bicarbonate. This will simply confirm the finding that the problem is metabolic acidosis. In this case, calculate expected PaCO2 by the compensatory formulas. Again, let me bring this table back over here. In this case of primary metabolic acidosis, we will use this formula. Now see, if real PaCO2 of the patient is same as the expected PaCO2, then it is compensated metabolic acidosis only. If the real PaCO2 is less than the expected PaCO2, then it is mixed disorder of primary metabolic acidosis with concomitant respiratory alkalosis. As already I have told, PaCO2 is an acidic gas. So, high means acidosis and low means alkalosis. If PaCO2 of the patient is more than the expected that we calculated based on these formulas, then it is also a concomitant respiratory acidosis along with the primary metabolic acidosis. So it is useful to find the expected PaCO2 value using this formula. Simple, isn't it? Next step is to calculate the anion gap. Always remember to calculate anion gap, especially in the case of metabolic acidosis. Repeating again, anion gap is sodium minus chloride plus bicarbonate. Its normal value is 8 plus minus 4. So it is usually around 10 to 12. If in a case of metabolic acidosis, if the anion gap is normal, then it is most likely hyperchloremic metabolic acidosis, and the possible causes can be summarized by the mnemonic ACROIT. If the anion gap is high, that is more than 20, then it is high anion gap metabolic acidosis, and the possible causes can be remembered by this mnemonic KUSMALE. There are several mnemonic available, but I like this one as it sounds like Kussmaul's breathing, which is also seen in case of metabolic acidosis. In case of KUSMALE, K stands for ketoacidosis, U for uremia, S for salicylate, M for methanol, A for aldehydrate, L for lactate, and E for ethylene glycol. Next step is to calculate delta anion gap. This should be done even when pH is normal. So delta anion gap is nothing but patient's anion gap minus normal anion gap, that is 10. So patient's anion gap minus 10, that is delta anion gap. In the next step, you calculate the corrected or potential bicarbonate level. Here, you just have to add the delta anion gap with the measured bicarbonate level, that is the patient's bicarbonate level. Now, if this corrected or potential bicarbonate is more than 26, then A metabolic alkalosis is also present. And if this corrected or potential bicarbonate is less than 22, then there is also a coexisting non-anion gap metabolic acidosis in addition to the anion gap metabolic acidosis. So as you can see, the basic calculations can help you identify mixed disorders also. Similar rules should be followed when the pH is on the higher side, that is on the alkaline side. This is the summary of those steps that we already discussed. Even mixed disorders can be identified if you complete all the steps. Now, let me tell you a tricky situation. Here, there can be a situation where both PaCO2 and bicarbonate are contributing to the change in pH. In this case, you have to check the percentage difference. The one with greater percentage difference is the dominant disorder. For example, suppose the pH is 7.25 and PaCO2 is 60 millimeters of mercury. This indicates respiratory acidosis. So the bicarbonate should be high in order to compensate for this respiratory acidosis. But in this patient, the bicarbonate is 16 milliequivalent per liter. So there is also a metabolic acidosis. Now, which one is the dominant disorder? In order to find that, you find the percentage difference of PaCO2. So how to find it? Simply, you have to subtract the patient's value of 60 with the normal value of 40 divided by 40. So it is coming to be 0.5. Now let us see the percentage change of bicarbonate. So considering normal value of 24, we subtract it with the patient's value of 16 and divide it with 24. So you get 0.33. So the percentage value of PaCO2 is more. So the primary disorder is respiratory acidosis and metabolic acidosis is the concomitant disorder. Now coming to the most ignored value here in ABGA till now, that is PaO2. It helps you to determine the type of respiratory failure. Now I am going to simplify it over here. Talking about type 2 respiratory failure first. Remember, it is the result of poor ventilation, that is, the result of failure of the pump. So, along with low PaO2, there will also be a high PaCO2 in this case. While in case of type 1 respiratory failure, PaO2 will be low, but PaCO2 will usually be normal as the ventilatory function is normal. Now look at this ABGA report. Can you tell me what disorder it is? I really hope that you found this information useful. Thank you.